Hello and welcome. I'm Reverend Adam Marquette, pastor of Trinity United Church of Christ here in Wadsworth, Ohio. We are here in our space today for a special event. Warrior's Journey Home is a mission to provide spiritual healing and soul repair from the invisible wounds of veterans, families, and the community. It takes a community to heal the invisible moral injuries and wounds of war. This event is a community awakening to bring awareness to this mission and its goal of reaching out to our men and women who have served this country. Because of the current pandemic, we've had to do this a little differently. Instead of having you gathered here with us to learn more, we are coming to you. We have some great presentations in store. Dr. Aven from the Summa Health Traumatic Stress Center and Reverend Dr. John Schloop, founder of Warrior's Journey Home, will both be sharing, as well as a panel discussion with veterans and active military personnel. Along with Dr. Aven and Dr. Schloop, I want to say thank you to the members of the panel, Christopher Starr, Antigone Lowry, and William Berry, as well as Jason Sims and Peggy Hegbar for their work, as well as any others who helped behind the scenes make this event happen. Thank you for joining us. I'm going to turn this over to Dr. Aaron Aven to get us started.
I work at the Traumatic Stress Center. So what I specialize in is the psychological treatment of traumatic stress issues. So I do sometimes work with veterans, but I also work with a lot of other community members that are struggling with traumatic stress related issues. So what I'm going to focus on today in my presentation is defining trauma. So talking about the prevalence of trauma, both in the general population as well as in military populations, and then defining post-traumatic stress disorder. I'm also going to talk about treatment options. So we'll talk about pharmacotherapy. So these would be medications to address the symptoms of post-traumatic stress, as well as psychotherapy, or talk therapy is another way to think about that. And then also to just review some resources for informed decision making that can be helpful for people who may be struggling with traumatic stress issues. Commonly when I talk with people about what I do, in terms of being a psychologist that specializes in traumatic stress, a lot of people understand traumatic stress to be specific to military populations. So what we commonly think about when we think about PTSD or post-traumatic stress disorder is combat-related trauma or other military-related traumas. But as you can see from these images here, trauma is a little bit broader than that. So we know that it does not just affect people who have served in the military or have been involved in conflict or war. It affects people from various places, and it can relate to traumas that are experienced, such as natural disasters. So thinking recently about some of the hurricanes that we've had in our country, that certainly has resulted in some cases of post-traumatic stress. Terrorist attacks, other man-made disasters can lead to post-traumatic stress disorders. More commonly experienced things like motor vehicle accidents, other injuries, things like that. And then the images of children here to represent the fact that trauma can be caused by experiences in childhood, including childhood physical abuse, sexual abuse, or severe neglect. So we'll talk a little bit more about that today. Here we go. So when we think about trauma, what we're really talking about are extreme stressors. So these are things that are not normatively experienced as part of the human condition. All of us as people are going to experience stress throughout our lives. That may be stress related to losing our jobs or getting married. There are good stressors as well. Having children can be very stressful. But when we're talking about trauma, we're not talking about those kinds of stressors. What we're talking about are more extreme stressors. So these might include things like serious accidents, natural disasters, or man-made disasters. Trauma also includes criminal assault or rape. Domestic violence would be included here. Child sexual, physical abuse, or neglect. Witnessing a traumatic event, even if you were not personally harmed, sometimes witnessing a serious trauma happen to somebody else can result in some traumatic stress reactions. The traumatic loss of a loved one, for example, through murder or suicide or accidental overdoses, those types of things can result in PTSD. being kidnapped or taken hostage, experiencing a terrorist attack, experiencing torture, being incarcerated as a prisoner of war. Being diagnosed with a serious illness is another event that can be experienced as traumatic. And then, of course, combat or experiences of war. So one of the things that is widely debated in my field, in the field of behavioral health in general, is the definition of trauma. So there are some definitions that are very narrow, and I'm going to talk a little bit today about the way that the Diagnostic and Statistical Manual of Mental Disorders, which is kind of like our manual that guides what we do as behavioral health practitioners and what types of problems we look at and how we identify those problems. That takes a more narrow view, but there are others in the field who prefer a broader view of trauma. So this definition I like, which says an event is traumatic if it is extremely upsetting, at least temporarily overwhelms an individual's resources, and produces lasting psychological symptoms. So this definition leaves it pretty open. And we'll see that there are other types of stressors. For example, from this list here, things like divorce. Sometimes in my practice, I do see individuals who are struggling with serious symptoms of traumatic stress after going through something like a divorce. Or working in a highly stressful or toxic workplace can sometimes lead to symptoms of traumatic stress. The experience of psychosis, so for individuals who have psychosis, the symptoms of psychosis can be experienced as traumatic. So if we think about individuals who may be struggling with experiencing auditory or visual hallucinations or delusional beliefs that may be very scary for them, that can lead to symptoms of traumatic stress. And then sometimes the treatments, unfortunately, that we need to utilize for individuals who have psychosis, such as restraining them or kind of involuntary administration of medications if they're a danger to themselves or others, can also be experienced as traumatic as well. Intensive care unit experiences, so people who have a critical illness and need to spend time in the ICU may also develop symptoms of traumatic stress after their experiences. I've heard a little bit about this lately, especially with, since the COVID pandemic started, a lot more people talking about what we call post-ICU syndrome, or the experiences of traumatic stress that can happen after you do have a stay in the ICU, partly due to the critical illness itself, but also the treatments that are being given to people in the ICU can cause some experiences that may cause lasting distress. And the other stressor that I'll talk about that can relate to or can lead to traumatic stress issues is autism spectrum disorder. We know people who are on the autism spectrum are more likely to develop PTSD, and in part we believe that's because that they may be more likely to perceive certain events that the rest of us may not perceive as traumatic. They may be more likely to perceive those as traumatic due to their neurodiversity in the different ways that they perceive events and perceive the world. This is not an exhaustive list of other stressors that can lead to trauma-related symptoms. Again, referring back to that broad definition at the top, lots of events can lead to symptoms of traumatic stress for people if it kind of meets these criterion of being extremely upsetting, at least temporarily overwhelming their ability to cope, and then leading to lasting psychological symptoms.
Are you taking questions?
Absolutely.
So, does the medical profession believe that kids are born autistic, or is it a result of something that happens?
That's a great question. So the question is autism something that you're born with, or is it caused? And, you know, from my understanding, it's still something that we're trying to figure out and trying to learn about. So there are some theories out there that maybe it could be caused, but I think our current understanding is that we believe it's something that kind of occurs naturally. So we refer to that as neurodiversity. So there are a variety of things that can happen, including attention deficit disorder or autism spectrum disorder, that kind of, you know, mean that people may have differences in how their brains work and how they experience things. But thank you for the question. All right. Oop. Okay. So talking about the prevalence of trauma, if we look at estimates of how many people experience any sort of an extreme stress or a traumatic event, we see about 51% of women and about 61% of men experience one of those extreme stressors throughout their life, or at least one of those extreme stressors. In terms of the prevalence of PTSD itself, so these are people who actually meet the criteria for a post-traumatic stress disorder. What we see is the lifetime prevalence of PTSD is about 10.4% for women and about 5% for men. So we know that women have about double the risk of developing PTSD. And partly why we think this might be happening is because women are more likely to experience interpersonal forms of violence. So an example of that would be domestic violence. So interpersonal violence is any violence inflicted upon a person by another person. And so women are more likely to experience that, and that's part of our hypothesis for why they might be more likely to develop PTSD. If we look at particular populations, we also see that there's kind of various rates of the likelihood of PTSD. So if we look at the public mental health population, so these are people that are seeking mental health services, we see that approximately 50 to 98% of them have experienced some type of traumatic event in their lives. So very high rates in that population. And we also know that most people who've experienced one traumatic event have often experienced multiple traumatic events. Skip the slide. So if we look at military populations specifically, and research has looked at this in various ways. So they look at certain populations, so Vietnam veterans, for example, and try to get a sense of what the prevalence of PTSD is in these different populations. What we see if we look for point prevalence, so this point prevalence means at a particular point in time, how many people have PTSD. So estimates for the point prevalence of PTSD in military populations, including a broad set of military populations, ranges anywhere from 2 to 17%. Lifetime prevalence, which is a different type of statistic that tells us kind of more what is the likelihood that somebody over the course of their lifetime will experience PTSD. Those estimates range from 6 to 31% in US military populations. Studies have looked at current service members to get a sense of what might be the rate of PTSD in those populations. So a RAND Corporation study from 2015 found that about 8.5% had likely PTSD among current service members, and about 9.4% had likely depression. And we get different ranges of kind of percentages depending on how we're asking the question. So if we ask people to self-report, we may get one percentage. If we ask clinicians, if we have people actually come in and meet with somebody who's a trained mental health clinician to do a diagnostic interview, we may get different estimates. So that's why there's such a broad range in terms of these estimates. In terms of Vietnam veterans, the lifetime prevalence rates for PTSD in that population ranges from 14 to 30%. So you can see just in general, there's a trend here in military populations to be more likely than the general population to experience PTSD. If we look at Operation Desert Storm, the point prevalence rates for that population range from 6 to 16% for deployed veterans. So this would be looking at those veterans when they were deployed. At that point in time, the rates ranged from 6 to 16%. And if we look at OEF and OIF point prevalence rates, we see that ranges from 4 to 19%. Specifically, a study from the RAND Corporation from 2009 found a 14% rate of PTSD among that population and a 14% rate of depression. So that's pretty high. That's a lot higher than we would anticipate to see if we compared that to our general population prevalence rates. We also know that the rates of exposure to trauma in this population were pretty high. So if we look at this list here, we know 50% of those veterans had a friend seriously wounded or killed. That's a very, very high rate of trauma. 45% reported seeing seriously injured or dead non-combatants. Dr. Schloop is going to talk in a separate presentation today about moral injury. And some of the types of trauma on this list here relate directly to moral injury. And what a moral injury is, and Dr. Schlup can probably define this more eloquently than me, but any time that there is a perceived violation of one's deeply held moral principles, either by oneself or by trusted others. So seeing seriously dead or injured non-combatants, being responsible for the death of a civilian, witnessing brutality toward prisoners, detainees, these could all be events that could relate to moral injuries for people. Okay, so after somebody experiences an extreme stressor or a traumatic event, there's a variety of reactions that they may experience. There are short and long-term reactions. So I work with people in an acute care hospital setting directly after they experience traumatic events. So I might see people after they've been through a very serious motor vehicle collision, or I might meet with them after they've been the victim of an assault, things like that. And what I see is short-term, there's a lot of things that are very normal to experience, right? So if any of us were to go through one of those events, it would be very natural and normal for us to have fear and anxiety, perhaps shock and disbelief, right? These are very normal responses to traumatic events. Some of those reactions can become longer term for people, so sometimes that fear and anxiety can persist over time. There can also be dissociation or dissociative experiences, including confusion, shock, feelings of disconnection from current reality or disconnection from one's sense of self, or an inability to believe what happened. Anger and hostility are commonly experienced, which makes sense, right? If something terrible happens to us, it would make sense that we would feel angry about that. Grief and sadness, guilt and shame. Auditory hallucinations and paranoia can happen for some people. So auditory hallucinations might include hearing things that may have happened at the time of the trauma, or hearing voices, things that may have been associated with the trauma. Feelings of hopelessness, difficulties with sleep, suicidality, substance abuse, and I'll talk a little bit more about that a little bit later in the presentation, but substance abuse is a common reaction to trauma. Substances can be very effective in the short term at helping to kind of reduce the distress associated with trauma, so it's not uncommon for people to struggle with that. Impulsive and or self-destructive behaviors are common reactions. Emotion regulation problems, so having difficulty keeping those emotions regulated. And then also relationship problems, including sexual difficulties, are common for a lot of people after a trauma. So today I'm going to focus on PTSD as a consequence of trauma exposure, but there are more consequences than just PTSD. So not everybody goes on to develop PTSD. But some people may go on to experience other consequences such as depression or substance abuse or dependence. So some people go on to develop substance use disorders that may not have been a part of their lives prior to experiencing a trauma. Anxiety disorders are commonly experienced. Eating disorders, physical health problems are common consequences. And then, of course, relationship difficulties. And again, this is not an exhaustive list of trauma reactions or consequences of trauma exposure, but simply a list to kind of get a sense of what are some of the things that people might experience. Okay. I'll get there eventually. All right. So as I mentioned, I'm going to talk about how the Diagnostic and Statistical Manual of Mental Disorders defines post-traumatic stress disorder. Post-traumatic stress disorder was first introduced to the DSM in 1980, okay? Now, put that into the context of the DSM. The first edition of the DSM was published in 1952. So it was quite a long time until PTSD was recognized as a disorder. We know that PTSD was not a new thing that happened, obviously, in the 1900s. PTSD has been around for a long period of time. It's been talked about in various ways, but we know, obviously, as long as humans have existed, traumatic experiences have been happening to them. And so, of course, these experiences have been happening throughout history for people. So how the DSM defines post-traumatic stress disorder at this time is, first off, that in order to meet the criteria for a PTSD, a person has to have been exposed to actual or threatened death, serious injury, or sexual assault. So that could be through either experiencing that themselves, through witnessing somebody else going through that, through learning of that happening to a close friend or a family member, and also through repeated exposures to very aversive traumatic events or details of trauma. For example, first responders, including police officers or firefighters or EMTs, often develop PTSD as a result of that repeated exposure to traumatic experiences or details of traumatic events. Our current definition of PTSD says that we have to experience symptoms in each of these 4 categories to have the disorder. And so we'll talk a little bit more about what those symptoms look like, but they're intrusions, avoidance, negative alterations, and cognition in mood. And cognition is just a fancy word for thinking. And alterations in our physiological arousal and reactivity. So starting with intrusion symptoms, these are also often called re-experiencing symptoms because what they have to do with is they have to do with the person re-experiencing the traumatic event in some way. So one way that people can re-experience the traumatic event is through recurrent involuntary intrusive memories. So these memories are experienced as very intrusive by people, so they don't want to have them, they don't have control over when they occur, and they happen repeatedly for them and can cause a lot of distress. Another way that traumatic events can be re-experienced is through traumatic nightmares. So nightmares that have something to do either in theme or content with the traumatic event itself. Intrusion symptoms also include dissociative reactions. So another way that people sometimes re-experience the traumatic event can be through what we call flashbacks. Many of us might be familiar with this phenomenon because it's often depicted in television and movies and things like that. But this is considered to be a dissociative experience. So when people are having a flashback, they lose some sense of connection to the current time, the current surroundings, the current realities, and get kind of pulled back into re-experiencing their traumatic event. Another intrusion symptom is having intense or prolonged distress after exposure to traumatic reminders. So it may take people hours or days even sometimes after they're exposed to what we may call a trigger or a trauma cue after they've been reminded of their event in some way. And then the last symptom here in this group is marked physiological reactivity after exposure to trauma-related stimuli. So people may have very strong physical reactions. They may have stomach distress. They may have panic attack-like symptoms, things like that that cause very extreme physical reactions. So for a diagnosis of PTSD, you have to have at least one intrusion symptom.
Just a quick question. Is there any evidence, scientific evidence base that prolonged exposure to traumatizing events change us cognitively, biologically, physiologically, hormonally, I guess all the above?
Yes.
Okay.
Yes. So great question. So is there evidence that these types of reactions can actually change our biology? Is that kind of what you're asking? And yes, there is. So we know that trauma, especially when trauma happens to children, right? We know that that can change our neurobiology. So how our brain is working, the pathways in our brain, those kinds of things. People who have experienced trauma are going to be more sensitive to danger cues in their environment. So their fire alarms are going to be more likely to go off as compared to other people who have not experienced trauma or been exposed to traumatic stressors. So yes, there are physiological changes. What we know, the good news is that we know that treatment can help to address and reverse some of those changes.
Is the does that also apply in transgenerational symptoms that are passed on from one generation to the next? And the reason I bring it, I'm thinking about slavery, its impact on our nation, our communities, thinking about separating children from their parents at the border and then not being able to reunite them. And those traumatizing events are going to be, those symptomology will pass on from one generation to the next. Is that a safe assumption, or is that some evidence that?
Yeah, so what we know is that there is some evidence to show that there can be kind of generational transmission of some trauma-related things. So the epigenetic research, and I'm not an expert in this, but has shown that, for example, groups of people like Holocaust survivors, their children may be more susceptible to certain types of stressors or things like that based on kind of, this kind of generational transmission of trauma, absolutely. And there's certainly theoretical work out there that would suggest, for example, looking at slavery, that the way that history can be transmitted generationally and cause lasting effects, even generations down the road for people. Absolutely. So that's a good question. The second group of symptoms is the avoidance symptoms. So it's very logical that if we were to experience a traumatic event that caused us harm, either psychologically or physically, that we would want to avoid that, right? That it's absolutely logical, so it makes sense. And so in the short term, this is really normal after experiencing a trauma, that we might not want to think about it, might not want to have any reminders of the trauma, might want to avoid people, places, things that remind us of the trauma. So we see avoidance happening in two ways. So there's internal avoidance, so we avoid internal stuff like trauma-related thoughts and feelings, and we avoid external stuff like people, places, types of conversations, activities, objects, situations, certain sensations that may be trauma-related reminders for us. And so for people who have PTSD, we see people engaging in at least one of these types of avoidance. And I'm going to talk a little bit more about avoidance because it's a key factor in kind of what we believe maintains PTSD, and it's also a modifiable factor, so it's partly what we address in treatment when we work with people with PTSD. The third group of symptoms are called negative alterations in cognitions and mood. You have to have at least two of these symptoms in order to have a diagnosis of PTSD. What we know is that in order to kind of qualify as being related to PTSD, these symptoms have to either have began or worsened after the traumatic event. So this can include inability to recall key features of the event, and this would be not due to an organic factor. For example, if somebody has a traumatic brain injury or experienced a loss of consciousness at the time of the event, we wouldn't expect them to have memory of that. So outside of organic reasons for why they might have memory loss, some people do have some memory loss associated with their traumatic event. People may have persistent, distorted negative beliefs and expectations about themselves or about the world. So for example, seeing other people as completely untrustworthy or seeing oneself as totally incompetent. People can also develop persistent, distorted blame of self or others for the trauma and for the consequences of the trauma. So they may see themselves as solely to blame for something that logically most of us would look at and question their designation of blame for that event. Or they may see others, some other person or some other entity, as totally to blame for an event. People with PTSD may experience a serious diminishment in their ability to have a sense of interest in pre-trauma activities, so they may lose interest in things that they used to enjoy, stop engaging in meaningful activities. They may have a profound sense of feeling alienated from others, feeling unable to be understood by others, feeling unable to connect with others. And they may describe a persistent inability to experience positive emotions. So I often see in my patients a very restricted range of emotional experiencing. So they're not experiencing the good stuff, and they may be avoiding so much that they're trying very hard not to experience the more difficult emotions that we have as part of being human. And the last group of symptoms are the alterations in arousal and reactivity. So beginning or worsening after the event, people may experience more irritability or angry or aggressive behavior. They may engage in self-destructive or reckless behaviors. So they may just go out and take more risks than they used to take, or do things that could lead to serious harm, even if their intent is not to harm themselves. People often describe a sense of hypervigilance. So this is often people describe when they're experiencing hypervigilance, the sense of having to be constantly on guard, constantly aware of their surroundings, constantly scanning their environment for any potential threats or danger. So for veterans, this may look like them engaging in lots of checking of their locks and their windows, doing perimeter checks multiple times a day. If going outside of the house, needing to be very mindful of where one is in a room, to be able to have a good view of the whole room, to be able to monitor any potential threats, any doorways, any exits, those kinds of things. People with PTSD often have an exaggerated startle response. So I often see this in my patients where when I go to get them from the waiting room, if there's a loud noise outside the hallway, they may jump out of their chair, right? So a very exaggerated startle response in reaction to things that may not make the rest of us jump out of our skin. Commonly also experienced are problems in concentration and then sleep disturbance. Even outside of the experience of nightmares, people with PTSD are often having difficulty getting to sleep, staying to sleep, and those kinds of things. Okay. In addition to PTSD, an idea that I wanted to talk about today was complex PTSD, because I hear it talked about a lot by people that come in to see me, by my clients. I hear it talked about more and more in kind of the popular media, is this idea of complex PTSD. So I wanted to define that and just talk a little bit about how that relates to PTSD itself. So complex PTSD is a newer construct with a smaller body of research than traditionally understood PTSD. What we do know is that the current research that we have does support this as being a distinct diagnosis from PTSD itself. And it is actually going to be included in the next version of the ICD, which is the International Classification of Diseases. So I talked about the DSM, or the Diagnostic and Statistical Manual. The ICD is used more broadly. It's used internationally, and it's used by the medical community to classify and understand diseases. So complex PTSD is going to be included in the next version of that. So what complex PTSD is it's a combination of all of the stuff that goes along with PTSD, as I just defined. But in addition to that, people with complex PTSD have disturbances in their self-organization. And what we mean by that is that they have pretty marked emotion regulation impairments. They have pretty markedly impaired senses of self. So they may have a very stable negative view of themselves that persists over time and doesn't change. And they may have very marked interpersonal relationship problems. And so that's kind of what we see in complex PTSD. We know that complex PTSD is associated with childhood interpersonal trauma. So we're going to be more likely to see that in people who've had a history of childhood trauma. Yes?
There have been several small studies lately that have shown that military members and first responders have higher adult childhood or adverse childhood experience scores, ACEs scores.
Mm-hmm.
Would that also tend to make them more prone to having complex PTSD?
Yes. So the question was, yes, we found that military members are more likely to have these higher rates of ACEs, right, adverse childhood experiences, and does that make them more likely to experience complex PTSD? And yes, I think that you're absolutely right on there. So yeah, I didn't focus on the ACEs here in this presentation, but we do know that ACEs are going to put somebody more at risk for experiencing these types of impairments, in addition to all kinds of other things like substance abuse and psychiatric illnesses and things like that. But absolutely, and that's a great question. And so I think it's important to recognize in the military population, in the veteran population, there are people whose trauma did not begin with their military experiences, right? So they might be experiencing more complex PTSD reactions that would be important to look at. We know that people with complex post-traumatic stress disorder tend to have more severe functional impairments, and they have longer courses of treatment. So it's a little bit more complex to address this type of PTSD for some people. So, yes?
Is it true that some people with post-traumatic stress disorder can seem to be fine carrying on their life and then have like situations come up that take them back into their PTSD, and they may not either have had any kind of treatment, or B, be currently treated, and so they go along in life, but then experience the lows and some of the symptoms of PTSD, and then what are the options for them?
Yes, good question. So can somebody live with this for a long time and function well, and then have something occur that causes them to have an exacerbation of symptoms, more problems functioning? Absolutely, absolutely. There are, certain things that can happen. So, stuff happening in the world, right? So new conflicts happening in the world. Certainly this year has been a particularly difficult year for all of us, but particularly for people that may have a history of trauma. And the ways that this has affected our life could cause them to have more symptoms than they may have had previously. So yes, it is something that can absolutely be fluid and can change over the course of the lifespan. And so there are options, I suppose. People, sometimes people do return to treatment. For example, I work in the Traumatic Stress Center, and I have had the experience of successfully completing treatment with somebody and saying goodbye, and then having them come back when something new has occurred in their lives, and they're finding that they need to address some more trauma-related symptoms and work on that again. So there is, from my perspective, of course, since I focus on kind of the psychological treatment, that's always an option, is going back to treatment. Other options are, sometimes people need to increase their engagement of communities of support. So that could be a religious community, or it could be, a neighborhood community, or a volunteer organization that they're a part of to try to help. So sometimes those things can help as well, or to just use their social and family supports to work through things that are going on. So there's a variety of options. I mean, certainly this type of treatment is one option, not the only option for people.
And so you're affiliated with SUMO, but how are insurances? Because a lot of people depend on if their insurance is going to pay for it, they'll seek treatment. So what does the insurance community do and or cover? How do they cover PTSD?
Well, currently, all behavioral health treatment is covered by insurances. It's required to be covered. So this type of treatment would be covered. So if people have insurance, then yes, they have options. They can definitely seek out, and even if it's Medicaid insurance, right? Our clinic takes that. There's multiple agencies in the area. Summit County is where I work, so I'm most familiar with those resources, but there are other resources. Is Wadsworth and Summit? I'll admit
Wadsworth is in Medina County.
Okay. So, and in Medina County, so there are going to be certain agencies where people could go to get that type of support. Absolutely. But it is required to be covered as long as people have insurance. I know in Summit County, we have programs where people can get help even if they don't have insurance. I'm not as familiar with what Medina County has. In Summit, we have a tax levy that covers that for people. Sure. So not everybody who experiences a traumatic event is going to develop PTSD, right? So there are certain risk factors. One risk factor is the severity of the trauma itself. Another risk factor is the frequency of the trauma. So is this something that's happened repeatedly over the course of their life? The duration of the trauma, was it time limited, or was it an ongoing type of thing? Having limited social support is another factor that can in fact impact somebody's likelihood of developing PTSD. The good news about that is that's somewhat modifiable, so we can help people to increase their social support, which can help them to adapt in healthy ways to a trauma. Another risk factor is interpersonal trauma. As I mentioned earlier, women being more likely to have PTSD, we think in part it's because they're more likely to experience interpersonal forms of trauma. Another risk factor is the perceived dangerousness of the event, right? Notice the perceived there. So not necessarily the objective dangerousness of the event, but if somebody perceived it as very dangerous, then that could be a risk factor for developing PTSD. And another risk factor is a history of psychiatric illness. So if somebody was already struggling with depression or anxiety, then that might put them more at risk for PTSD.
Dr.
Yes.
This is a comment, not a question, but
Okay.
you may want to comment on my comment.
Sure.
In the alterations and arousal and reactivity, I don't want to get too far away from that because a lot of those things that we talk about as symptoms become normal for persons who are in the military, especially when they leave the wire and go out into a hostile environment. And that saves lives. The hyper-arousal, hypervigilance, just being aware of what's going on and being able to react to specific situations that we've been trained to react to.
Yes. So they are adaptive reactions. You're absolutely right.
Yeah, and the problem is we don't teach people how to turn that off when they come home. That's been my experience with working with veterans, and so it's just a comment that it's one of those issues that, man, that's a sticky wicket to try to get a hold of.
Sure. Yeah. So the comment is, these alterations in physiological arousal and reactivity are actually very adaptive in certain contexts. And you're absolutely right. And so, and I'm going to talk about this a little bit, but how we kind of view, traumatic stress symptoms is those start as normal reactions, right? So it would be normal to be hypervigilant when you are on active duty in the military and you have to go into a hostile territory, right? It would absolutely benefit you to do that. And you're right, it's hard to turn that off though. Once that training becomes, overlearned and automatic, it's very difficult to turn that off. And that's why when we shift contexts then, and then you're home and you're in your house with your family, and you're still engaging in some of those behaviors and still feeling very hypervigilant, that's where it can become less adaptive for people and more problematic. Yes?
I have a question regarding the risk factors. You talk about frequency, but the way you spoke about it, it seems as though you're talking about frequency of the same traumatic event. So say domestic violence, if it occurs more than once. So how does cumulative separate traumatic events affect the likelihood of PTSD?
Absolutely, it would. So even if it was a different event, so for example, you experienced domestic violence and then you joined the military and then you experienced military-related trauma, yes, absolutely, that's going to increase your risk.
Okay, thank you.
That's a great question. Yep. Okay. There we go. This is the slide that I wanted to get to. So what this shows is, this shows the comorbidity of other types of mental health issues for people who have PTSD. So you can see that the purple bar here is females and the white bar is males. And what this represents is the percent of people with PTSD who have other types of issues as well, other diagnoses. So as you can see, major depressive disorders experienced by basically almost 50% of men and women who have PTSD, right? So a very high rate of comorbidity. So seeing these two things happen together very frequently. Substance use disorders are also happening very frequently for people with PTSD. So and particularly if you look at alcohol use disorders in men, very high rates, over 50% of that for people who have PTSD. And then, drug use or drug dependence. And then these over here, generalized anxiety disorders, the GAD, panic disorder, social anxiety disorder, and agoraphobia. So we see that there's a range of other issues often going on for people with PTSD. So it's not always very simple. So all of these things would need to be addressed in treatment. So I'm going to shift into talking about the treatment of PTSD. So once we've identified it and we know somebody is having traumatic stress symptoms, what do we do about it? One option would be medications. I'm a psychologist, so I don't prescribe medications, but a lot of my patients are taking medications. So I'll talk a little bit about what we know of the medications at this time. So a recent review, which was published in 2017, which talked about treatment guidelines in general for PTSD, basically said that they conditionally recommend certain medications for the treatment of PTSD, including the ones listed here. So sertraline, paroxetine, fluoxetine, and venlafaxine. Those are the generic names. The brand names of these are Zoloft, Paxil, Prozac, and Effexor. So people are probably more likely to have heard of them by their brand names. But these medications received conditional recommendation. And basically what that means is we have enough evidence to say that they're helpful to some extent for people, but we don't have a super strong body of evidence that says, yes, these are going to be greatly helpful for everybody. So they're conditionally recommended. We know that the FDA has only approved sertraline and paroxetine for the on-label treatment of PTSD. But for those of you who are familiar with kind of how medications are prescribed, they're not always prescribed on label. So sometimes people are given other medications that we have some indication, some evidence to indicate it might be helpful for them. Another recent review, which was published this year by the International Society for Traumatic Stress Studies, classifies these medications, so the 4 listed there, as interventions with low effect. Again, what that means is they have an effect. They're helpful to some extent. They're not having huge effects. We're not showing very big effect sizes in terms of reducing symptoms and improving functioning for people with PTSD. But they can be helpful, and they certainly can be a part of the treatment that's helpful for people with PTSD. Another type of treatment is psychotherapy, so talk therapy. This is what I specialize in. And when we talk about psychotherapies, there are a couple of considerations that we need to make. One of those things is determining a person's readiness for treatment. So I talked about complex PTSD. So oftentimes people with complex PTSD, because they're having such severe problems in their relationships, regulating their emotions, feeling okay with themselves, they may not be ready to walk into my door day one and get started with a trauma-focused psychotherapy. I'm going to talk more about what those psychotherapies look like, what we do in them, and how we think that they work. But they are difficult therapies, right? So they all involve, in some regard, essentially talking about or thinking about the traumatic event, right? So that can be very distressing for people. So what we think about is we think about treating trauma through a staged model. So there's 3 stages. The first stage is addressing safety. So we know, for example, suicidality is not uncommon for people with PTSD and trauma-related issues. And if that's a factor when somebody walks in the door, we need to establish safety first. So we can't jump right into talking about trauma until we help that person feel a little bit safer and develop some coping skills and some emotion regulation strategies. Be able to manage basic self-care. Some people do find self-care to be very difficult when they're struggling with PTSD. And so we want to start there and work on establishing some stability and safety before we jump into trauma-focused work. So stage 2 is trauma processing therapy or trauma-focused psychotherapy, which I'll talk about in more detail today. And then stage 3 is after we've kind of completed the trauma-focused psychotherapy, then we focus on helping people to reconnect with things that are valuable and meaningful in their lives. So that could be with relationships, with work, with other activities that they would like to engage in. And some people really only need the trauma processing therapy and don't need to spend a lot of time in stage 1 or stage 3 therapies. Other people may need to spend a significant span of time in stage 1 and or stage 3. So stage 1, again, targets those coping skills, emotion regulation, interpersonal skills, and substance abuse issues. So if somebody comes to my office and they're in the midst of a severe substance use disorder, we're also not going to start trauma-focused psychotherapy that day, right? We're going to make sure that they get the treatment that they need to stabilize that substance use disorder first. And then in stage 3, we support people in really effectively engaging in valued relationships and life domains. This might mean for somebody going back to work. Maybe they've been out of work for a while, or going back to school if they have educational goals that they would like to attain, or learning how to develop social relationships and have relationships with other people, which can certainly be disturbed for some individuals. In terms of treatment using psychotherapy, treatment for PTSD, these are again the stage 2 treatments. I'm going to talk about 3 different treatments that are kind of most commonly used. So when people go to trauma-specific treatment these days, these are the ones that they're probably going to be most likely to complete. This is not an exhaustive list, and we have other trauma-focused psychotherapies that have been developed specifically to help people with PTSD and trauma-related issues, but these are the ones that I'll focus on. The first 2 are prolonged exposure therapy and cognitive processing therapy. These are both, they fall under the umbrella of cognitive behavioral therapy. So cognitive behavioral therapies essentially look at how our thoughts and behaviors relate to the problematic experiences and emotions that we may have. And so I'll talk more about those 2. And then the third one is eye movement desensitization and reprocessing therapy. I hear a lot about this these days. It's EMDR for short. And it is historically controversial in the field of psychology because there's been some inconsistent findings over time about what exactly are the change mechanisms. So I'll talk a little bit about that more. But in general, EMDR does have pretty good empirical support, a growing body of research support that grows every day. And it is recommended by some treatment guidelines as a first-line treatment at the same level as PE and CPT, which I'll talk about. So in terms of the underlying theory for treatment of PTSD, as Dr. Schlup brought up earlier, right, some of these reactions that people have, these symptoms of PTSD that I described to you, really seem to be normal responses to abnormal events or situations, right? So if you're in the military and you have to go outside of the wire, as you said, every day, then it's going to be really normal for you to be on guard, to be prepared for danger, to be easily startled, because that's going to help to keep you alive. So even outside of military-related situations, we see that trauma symptoms begin as survival strategies, right? So it makes sense, gosh, if you've been really hurt in a motor vehicle accident, it would make sense, gosh, I don't want to get back in a car because I don't want that to happen to me again. Unfortunately, that's not necessarily adaptive, right? Especially living in Northeast Ohio, where it's very difficult to exist without getting into a motor vehicle or a bus or some form of transportation that's going to move you from one place to another, because we don't live in tiny communities where we can typically walk to get our groceries and walk to work and things like that. So these symptoms begin as survival strategies, but often outlive their usefulness. And so that's where PTSD becomes a problem. So now, the person is spending hours a day checking their windows and checking their doors and walking their perimeter, and that's going to interfere with life, with the ability to have a job, have relationships with your family and your friends in effective ways. So we know that many people commonly experience these symptoms after exposure to a trauma. So when I see people in an acute care setting days after they've experienced a trauma, it's really normal, right, to not want to talk about it or think about it or to feel really upset when you think about it. We know that most people naturally recover over time, so most people don't go on to develop PTSD. Okay, so we believe that we kind of are programmed to have a natural recovery process from PTSD. But what happens when PTSD occurs is that natural recovery process gets derailed. And so our theories say that if the natural recovery process is derailed, what we need to do is identify what's maintaining that derailment, what caused it and what's maintaining it, and help to reverse those processes. So we look at 2 main things that we believe do impact people's recovery from trauma. So the first big thing is avoidance. So we believe that avoidance, even though it's totally normal, right, to not want to think about something that's distressing, that avoidance over time, what happens is if we don't think about it, if we don't integrate it as part of our history and our memories, then it kind of gets stuck as a current event, and we're not able to reduce that emotional arousal and that fear response. We're not able to have the new learning that occurs with being in situations where we would discover that, oh, I can safely drive in a motor vehicle, or I can safely go to the grocery store without something terrible happening to me. That if we're avoiding doing those things, then we're not ever going to have that natural learning process occur. And the other piece are the maladaptive cognitions, or the unhelpful thoughts or beliefs that can happen after trauma. And so these thoughts or beliefs, an example of that might be, the world is never safe. I must be on guard at all times. Those thoughts and beliefs can lead to really unhelpful, both emotional and behavioral responses that maintain or increase those PTSD symptoms over time. So our treatments, our psychotherapies target exactly these two things: the thoughts underlying the trauma and the meanings associated with the trauma, and then the avoidance. So the first thing I'll talk about here is prolonged exposure therapy. We call it PE for short. It's a little bit easier to say. So in prolonged exposure therapy, what we really emphasize is that we believe PTSD to be the result of cognitive and behavioral avoidance. So that's exactly what we target in the treatment, is the avoidance. And the goal in PE is to promote engagement with the feared and avoided internal and external reminders of the trauma. Now, these are objectively safe reminders of the trauma. So we never have anybody exposing themselves to unsafe situations or realistically dangerous things. But people often with PTSD are avoiding things that are objectively safe, and most of us are experiencing them as such on a daily basis. So in PE, what we do is we work towards that goal of increasing that engagement and reducing that avoidance in two primary ways. The first is through exposure. And there's two types of exposure in prolonged exposure therapy. One type of exposure, we call it imaginal exposure, and this is where the person revisits the trauma memory with the therapist in session. It's kind of like just telling the story of the trauma and allowing the natural processing of emotions associated with the trauma to occur. And then also in vivo exposure, or in real life exposure, which is typically exposure that happens outside of the therapy room for people. So this might include things like going to the grocery store if a person has been avoiding that for fear, or driving in a car, riding on public transportation, going to the VA, or attending veterans events. For a lot of veterans can be pretty activating or triggering events. So those things might be in vivo exposures that we might support somebody to do. The treatment is very individualized, so the exposure assignments that are given are based on exactly what that person is avoiding. So the person works with the therapist to develop what we call an exposure hierarchy, and then works through that hierarchy to increase their engagement with the goal of reducing that fear and reducing that avoidance. And we know that the treatment is effective at that if people stick with it. It's a difficult treatment. All of the treatments that I'm talking about today are difficult because they do involve the exposure to the events themselves and the distressing memories. The other way that the goal is achieved in prolonged exposure therapy is through discussing and changing the meanings and beliefs associated with the traumatic event that may have become unhelpful, unbalanced, or unrealistic. So the examples I put up there might be something like, I could have stopped it, right? So this might be a belief that could perpetuate problems for people, can perpetuate this distorted sense of self-blame, especially if the reality is that they probably didn't have too many options available to them at the time of the trauma. Another example might be, it's my fault for leaving the party early, right? So we want to bring these beliefs and meanings to the surface so we can look at them. It's not the therapist's job to tell a person what to think or believe about their trauma, but rather to bring this stuff up so that they can examine it, and the therapist just supports them in looking at it themselves. So some of the important treatment components include psychoeducation. So this is a big piece of all of our trauma-focused treatments, really, is just giving people information, helping them to understand PTSD, why it's happened, what's maintaining it, so that they can have the knowledge that they need to really help themselves get better. Anxiety management skills, so we teach breathing retraining or relaxation skills, and then again, the in vivo exposure and the imaginal exposure pieces. The second therapy that I'll talk about is cognitive processing therapy, or CPT for short. So the theory underlying CPT is a little bit different than prolonged exposure therapy, very related, but a little bit different. So the focus here is that we believe if somebody has not recovered after a traumatic event, we believe that something is blocking their recovery. So our goal in cognitive processing therapy is to figure out what's blocking their recovery, and then hopefully to reduce or remove those barriers to their recovery. And so the barriers that we look for in cognitive processing therapy include unresolved emotions. So when we avoid thinking about a traumatic event, when we avoid reminders of traumatic events, essentially what we're doing is blocking our own natural emotional recovery process. And so our goal in CPT is to help people to experience their natural emotions that may have been blocked or suppressed. So we believe that's part of the healing process and part of what helps people to get back on track with their recovery when they've been derailed. The second piece that we look at in terms of barriers are unbalanced thoughts, or what we refer to as stuck points. And a stuck point is an unhelpful or unrealistic or unbalanced thought or belief related to the trauma or something that was strengthened by the trauma that's essentially, we believe, keeping a person stuck in their healing. So we want to, again, identify those thoughts and beliefs and then help the person to use some strategies to examine those. And again, it's not the therapist's job to tell them what to believe or what not to believe, but to help them to learn skills, cognitive therapy skills that they can use for themselves to examine those thoughts and beliefs and decide what makes sense to continue to believe and hold on to, and what might make sense to reimagine or to adjust. In cognitive processing therapy, again, we include education. So we do, give people information. Here's what PTSD is. Here's what we believe is keeping you stuck in your recovery. Cognitive processing therapy uses a lot of writing assignments to explore the impact and the meaning of the trauma for the person. It's a very worksheet-heavy therapy. So, if somebody responds well to that type of therapy, they often do well with cognitive processing therapy. And then again, cognitive therapy techniques. So cognitive therapy has been adapted to address all kinds of problems that affect people, one of them being post-traumatic stress disorder. And what we know is that cognitive processing therapy, there's a couple different ways that you can do this therapy. One way that you can do it is to have somebody complete a written account of their trauma. Another way is to just focus on the cognitive therapy elements and the impact and meaning of the trauma and not have them write about the trauma. And what we know is it's effective both ways. So some people have a really strong desire not to do the written trauma account, and we know that this can be a helpful treatment for them even if that's the case. And the last one I'll talk about again is EMDR, or eye movement desensitization and reprocessing therapy. This is also a structured therapy. It's structured into 8 phases of therapy, which take approximately, on average, I think 6 to 12 sessions or so. But what's different about EMDR is it kind of has a different theoretical foundation than CPT and PE does. So it comes from kind of a different body of thinking. It involves the use of bilateral physical stimulations, which might include eye movements or taps or tones that the individual engages in while they are recalling trauma-related memories, thoughts, feelings, and sensations. So it's different than PE and CPT in that they're not talking about it verbally. They're privately recalling it and then engaging in these bilateral physical stimulations. The theory underlying this treatment is that PTSD is maintained by unintegrated memories. And so the treatment is believed to work by helping to facilitate the integration of those memories and the processing of those memories, and by allowing new learning to occur. Again, as I mentioned earlier, this is one of the more controversial treatments because there's some question in the research about whether we actually need the bilateral physical stimulation. Some of the research indicates that it's just as effective if you don't do the eye movements or the tapping. And there's other research that indicates that that is an actual active treatment ingredient. So again, it's a little bit more controversial, but overall, the research says that this is helpful. So whether we know why it's helpful maybe matters less, right? The fact that it's helpful is the important thing. So just in summary of these treatments, the trauma-focused psychotherapies are short-term, which is good. So approximately on average 6 to 24 sessions. That's not necessarily true for everybody. Some people spend longer time in treatment. For some people, it might be shorter. Some of these components can be delivered in groups. Cognitive processing therapy can be delivered in groups, which is nice. So that can help with kind of expanding the resources that we have available. And then also there's a type of learning that occurs in groups that can be really helpful. So when people can learn from one another and their experiences of healing, that can be really helpful. The therapies are adaptable for various types of trauma. So all of the therapies I discussed, EMDR, PE, and CPT, can be used to address just about any type of kind of traumatic experience or event that's prompted the PTSD. We know that they're all highly effective. They all have strong evidence bases. PE and CPT are universally seen across the guidelines as being first-line treatments. They're very effective. And EMDR, again, controversial, but still seen as being very effective. One thing I wanted to point out was that the quality of the therapeutic relationship is pretty important, so we know that that's a factor. So the more the person is able to connect with their therapist, feel a good fit there, feel understood, the better that they're going to do in therapy. So again, how they work is by challenging avoidance, allowing natural emotions to be processed, and identifying and changing any unhelpful thoughts about the meaning of the event to promote healing. Any questions about the psychotherapies? Okay. A really great resource for, oh, Jason.
Question about the
Yes.
availability of groups.
Okay.
I've been having trouble identifying or finding a group that I can get engaged with. How does one go about finding, particularly for combat veterans, how does one go about finding a group of combat veterans in therapy?
Good question. So the resource I'm going to talk about might be somewhat helpful. The VA is always a great resource. The Traumatic Stress Center, we do have groups there. We have, our groups are not specific to combat veterans, right? But we do have one group that we have one of our new postdoc fellows wants to run, and he wants to run a version of it that's just for combat veterans. But I'm going to agree with you that it may not be super easy to find such a thing, particularly outside of the VA system. I think it's going to be harder to find. That's why I think it's great that Warrior's Journey Home is in existence, because we need more resources like this for people and more options outside of traditional mental health treatment to help people who may need a group or want a group.
I might be surprised how difficult it is to find even within the VA.
Okay. Yeah, that's unfortunate that that's such a challenge. And unfortunately, I don't have any great insights in terms of how to go about that, other than, at the Traumatic Stress Center, we do our best to, if we have enough people to run a group, then we're going to do that. One of the challenges that we have is we don't always have enough people, and particularly with the pandemic right now, it's been a little bit challenging because we can only have so many people in a room at a time, and that's made it hard to do any in-person groups. So, yeah, that's a good question. I wish I had a good answer. Yeah. So one resource that is really helpful for a variety of reasons is the National Center for PTSD. They provide educational resources for people, both veterans who might be struggling with PTSD, as well as great resources for family, I think. One of the things that's really hard for veterans who return is that their families may not necessarily understand what they're struggling with and what they're going through. And so I think the National Center for PTSD does a good job in creating resources that can help families and friends to be better allies and better supports to veterans. So those are some great things on there. They have excellent resources for understanding PTSD, but also for understanding treatment options. So they have great, they have multimedia resources. They have videos that you can watch if you're more of a person who learns by watching or hearing somebody talk about something, but also a lot of written resources that can help people to be very active decision makers as regards to their treatment. So understanding the options, understanding the evidence underlying the treatments that we have and what's going to be helpful and those kinds of things. There is some support on that website for locating treatment and self-help resources, but again, as we are talking, it may not always have the answer for finding those or for exactly the right resource. There's also excellent resources for providers. So for the providers out there, people who are providing any types of service, educators, people in the mental health field, people who may work in the public sector and have a lot of interactions. So law enforcement officers may have interactions with veterans and other people struggling with PTSD. There's really great resources on there for people. So one of the resources that the National Center for PTSD offers are consultation services, so free consultation services for mental health providers like myself when we're dealing with issues in the treatment of PTSD. They have lots of continuing education resources or educational resources for providers treating veterans, and then trauma-informed care resources for various professions. So clergy, healthcare providers, law enforcement, and educators, there's really good resources for them on there. So highly recommend checking that out. And the last thing I'll say is, I think what's most important in dealing with anybody struggling with PTSD, including veterans, is remembering that how we interact with them, how we respond to them, makes a huge difference, right? So there's a great quote by Maya Angelou that I put on my slide, which is, people will forget what you said, people will forget what you did, but people will never forget how you made them feel, right? And so I think just doing our best to be as trauma-informed as possible, to be allies to people who may be struggling with PTSD is what we can do. And kind of just want to end with just an appreciation of Warrior's Journey Home. And I feel very grateful and lucky to live in a community where this is an option, because I think we need more options for people who are struggling with PTSD-related issues, other than just traditional mental health. I believe in what I do. I believe in traditional mental health treatments, and I believe that we need more than that. So we need communities of support that can help people in their healing journey. Because what I do with somebody is it's time limited. It's in a treatment room in a hospital, right? But once they leave my office, there needs to be more resources for them. So glad that this exists, and thank you to Dr. Sloop for continuing to make this available for people and for all of the people that help out with this project. It's a great thing. So thanks for having me, and I'll end there.